Well, good evening, everybody, and I want to welcome you today to our first of many series of Understanding Health Inequalities in Greater Cincinnati in America. My name is Jamie. I'm going to be your host and moderator for the evening, and I want to welcome you as we go through this very important series. First up, I want to introduce our distinguished guests. Our guests tonight are Dr. Anjanette Wells, licensed social worker, assistant professor, School of Social Work, and also Dr. Barbara Tobias. Next up, we want to just do a couple housekeeping items. As we navigate through WebEx, if you've never navigated before, you can see on the screen there's a couple important features to WebEx that you need to adhere to. The first is the main thing is that the mic looks like there is a line through it at all times, but if you are going to be muted, that area is going to be red. Okay. Make sure that your video is off during the WebEx. Also, we want to make sure that everyone knows that we are actually recording the event. So if you want to go back and reference the series later on, it will be recorded. And then there's also a chat option. If you have questions during the series, we will have a portion of the series that has a chat and answer, question and answer. You can be able to chat and send your questions, and we will answer them as we can. We'll move forward to the next slide. I already kind of talked about this a little bit. If you have any questions for the speaker at all, just send it into that chat box and we will ensure that we get the questions answered. If we don't get to all of them, we will forward the questions on to the presenters later today. So before we go into the actual presentation, I'm going to talk a little bit about Dr. Wells' background and her research. Dr. Wells is a licensed social worker and also has her PhD. She's currently the assistant professor in School of Social Work, College of Allied Health Sciences at the University of Cincinnati. She joined the university 4 years ago as a researcher with the Precision Cancer Cluster. She has substantial direct practice and experience with outpatient community clinics, inpatient hospitals, psychiatric units, and private practice. Her research focuses on community-based cancer prevention, as well as adhering to low-income minority women. She has established the groundwork for most of her research by showing the community engaged in interventions are critical to overcoming many of the disparities of cancer prevention. Dr. Wells also recently, in the past year, has been an integral part of a new book that's come out, Poverty in Place, Cancer Prevention Among Low-Income Women of Color. This publication features original research that examines the causes and consequences of women's cancer disparities. Dr. Wells continues to reach communities with her research through educating others about advanced clinical social work practice, research methods, diversity, and theory courses. Dr. Wells.
Can you hear me? Okay, all right. So good evening, everyone. I'm honored to be among the UC alum community. It's sort of a privilege to have kind of a unique way of bringing together the UC community and then the wider Cincinnati and community through technology. And I want to thank you for joining in and helping to kind of elevate these important issues related to health inequities and health disparities. So thank you for attending. You can advance it. Okay, so I sometimes open my presentation with these quotes that really kind of resonate with me and the work that I do. I also see disparities and inequities as more than just a medical or scientific issue, but also a moral and a social justice issue to understanding a lot of the racial, ethnic inequalities and injustices throughout the life course, particularly as it relates to health. So these quotes really get at the core of the work that I do. And then when we speak just broadly about health inequities and health disparities, we're also speaking about a lot of societal issues: access, poverty, homelessness, mental health, racism, bias. So I think it's kind of a larger conversation in at least beginning to move the needle forward and trying to address some of these multi-level um, inequities in our society. You can advance it. Okay. So you can't really solve a problem um, until you define it, and I think it's important to cover some of these important terms and concepts. Some I'm sure most of you have heard a lot of these terms kind of thrown around: race, racism, diversity and inclusion, health equity, health disparities, social determinants of health, cultural humility. Um, and I think although these terms are different, they are related. And they're related in the way of looking at health and why some groups have better outcomes than others. So a lot of these terms are kind of meet at the intersection of social justice and improving health among all Americans. And also some of the terminology though is evolving, so it's not used consistently by all researchers. For example, there's a trend now to move from the term disparity to equity, to health equity and fairness. Okay, you can advance the slide. Okay, so I'm going to start out with just a term I know we've all heard of: race. Um, it's it's sort of a lot to it, but it's been looked at over the years and has been shown to be is shown not to be entirely biological. So there's no gene or cluster of genes exclusive to all African Americans or all who identify as white. Okay, so race really should be reviewed or should be viewed as a social construct, because we know that individuals categorize others sometimes based on a variety of things: personal biases, psychological things, political, legal, historical influences. Um, so it's important to kind of keep this in mind, that it's not just a biological basis for it. Um, it is important, though, to when we think about some groups being predisposed to certain diseases like diabetes, cardiovascular disease, certain cancers, obesity. Um, it might have more to do with a combination of biology and environment. This what they call epigenetic expression or repression. But this still comes back to the idea that it's not entirely biological. Okay, you can advance it. Okay, so while the first thing that comes to mind when we think about sometimes diversity, we often think about race, but diversity is more than race alone. Diversity includes a multitude of these socio-cultural experiences of people and variations of different characteristics of people. Um, our cognitive skills, personality traits, age, sexual orientation, cultural background. social class, religious beliefs, immigration status, gender identity, and expression. So if you want to think about it in your own, with yourself personally, um, for example, in your work, you might interact with coworkers of different genders, age groups, religions, socioeconomic classes. So that's really what diversity is. We've also probably heard in our workplace the idea of diversity and inclusion, D&I, and it's really two distinct terms, and they kind of keep them distinct for a reason. So it doesn't. So just because you have a diverse group of employees doesn't mean that it's automatically an inclusive workplace where every employee is given opportunity and has value. So really to achieve both diversity and inclusion in a workplace or a hospital setting, an agency, social service agency or company, um, that would look like having a diverse group of people or teams dedicated maybe to designing some anti discrimination policies across the organization and really ensuring that all all candidates and employees get equal opportunities regardless of their diverse characteristics. Okay, you can advance it. So racism, it's come up in the past month or two with regard to our Cincinnati city council members. There's been a move to by the council members to introduce legislation to declare racism a public health crisis. So the legislation addresses racial disparities in healthcare and in health outcomes in our city. Uh, Communities like Columbus, Cleveland, and Hamilton County have passed resolutions, and the resolutions that declare they're declaring racism as a public health crisis, and that this would mean that the city would institute many more kind of systemic requirements and reform in law enforcement, business, housing, and also as it relates to this topic in the way of health and um, health outcomes. And and this is really important. Over the past 30 years or so, there's been more evidence-based research which shows that racial health disparities um, are due to racism. Um, and even more recently, research has shown that health disparities don't just affect poor African Americans, but it also cuts across class lines as well. There's a lot of data out there. I'll just highlight a couple things. Black Americans are 2 times as likely as other groups to die of COVID-19. And even before the pandemic, African Americans faced higher levels of heart disease, stroke, maternal mortality. There's a slide I'm going to talk about toward the end where it looks at life expectancy in predominantly white neighborhoods, which you can see can sometimes be decades longer than in predominantly Black communities, Black neighborhoods. Okay, you can advance the slide. All right, another term which is kind of we're sort of evolving from health disparities to health inequity or health equity. So health equity really is the desirable goal or the standard that we attempt at special efforts to improve the health of those who have experienced some disadvantage in the way of social or socially or economically. So it's the fair distribution of health outcomes and resources between segments of a population, regardless of social standing. On the other hand, health inequity is the difference in the distribution or allocation of resources between groups. So health inequities suggest differences or disparities that can be the result of unjust conditions. Health, if you look at, and I'm sure many of you have seen the picture at the right-hand corner, which shows the difference between equality and equity. And some have even gone even further with that diagram in looking at systemic barriers. So the fence can be looked at as a systemic barrier, and by addressing more systematic or systemic organizational structural barriers, you might remove the wooden picket fence and replace it with a fence where the whole game can be viewed by all of the people there, maybe by a wire chain link fence or something like that. So that's the idea with health equity or health inequity. Okay, you can advance it. Okay, health disparities. It occurs when a health outcome is seen to a greater or lesser extent between populations. So when that happens, it's considered a disparity. And although the term disparities is often interpreted to mean sometimes racial or ethnic, there can be many types of disparities. We'll look at a few kind of based on zip code toward the end of my part of the presentation. So as the figure shows, it shows African Americans make up only 13% of the U.S. population, but they represent almost 50% of all new HIV cases. So this shows a disparity between African Americans and non-African Americans. Okay, you can advance it. So this was, I think these images are a part of a media campaign from the project of American Academy of Physician Assistants, and the data highlights some results from the Institute of Medicine's review, and they reported that racial and ethnic minorities tend to receive a lower quality of health care than non-minorities, even when access-related factors such as patients' insurance status and income are controlled. So here, these are examples of that kind of highlight disparities in diagnostic testing, in just overall care, and medication treatment prescriptions. Okay, you can advance it. So this map, I don't know if it missed something at the bottom, but the map of the colored areas illustrate zip codes in Hamilton County. So this is the Community Needs Index, which is an objective and unbiased assessment of community need and socioeconomic barriers to healthcare. So the colors on the map correlate with need, with the blue or the purplish colors showing areas or zip codes with lowest need in Hamilton County, and then the red and orange being the areas of highest need. So the high need zip code areas consist of people more likely to have disadvantage in a lot of ways: accessing care, affording care, preventing and managing disease, obtaining an early diagnosis, having access to health information, and understanding medication and doctors' recommendations. And if you notice, UC is located in one of the high need areas in the that clustering of the red and orange areas. Okay, you can advance it. Okay, so when we drill in a little bit closer to Hamilton County, the most populous county in the region and home to the largest city, Cincinnati. We see zip code disparities reflected within this community needs index. So Cincinnati has a massive problem with poverty. Here's just some kind of startling um, statistics. According to the U.S. Census data in the Ohio Development Agency's Ohio Poverty Report in just 2018, there were almost 30% of Cincinnatians who live in poverty. It was 29.9%, and that's more than 85,000 individuals. Nationally, Cincinnati is among the top 15 poorest cities in the country with a population of 250,000 or more. And that's compared to a national poverty rate of 14% and an Ohio-wide rate of less than 15%. So all of those numbers mean that approximately 1 in 3 Cincinnatians fall below the poverty line, and our city's poverty rate is almost twice the national average. Okay, you can advance it. So this table kind of illustrates these zip code disparities. Residents of zip codes separated by really only a few miles away have up to a 15 to 17-year difference in life expectancy. And you'll also notice the predominance of race ethnicity in some of those zip codes. Okay. So another concept that I'm sure you've heard related to health disparities and inequities is social determinants of health. And it's really important when we look at kind of causes and consequences of these disparities. So social determinants of health are conditions in our environment that affect a wide range of health, functioning, and quality of life outcomes and risks. So for example, like the figure shows, economics, access to health, access to healthcare, genetics, health literacy, education level, neighborhoods, environment. So negative social determinants of health would be things like poverty, lack of access to healthcare, predisposition to disease, low health literacy, living in a unsafe environment. So all of these things lead to disparities, and they really affect all of us. If you kind of look at it, it's a lot. It's complex. There are a lot of intersections between all of these factors and a lot of different levels um, working at the same time. So it is complex, and when we look at solutions. Okay. So this is my last slide that I'm going to present, and it's just really one way of, I think, kind of mitigating and addressing some of the disparities with us personally. Dr. Tobias, who's going to speak next, she'll talk a little bit more about this, more probably on a clinical level, but I also thought it was a good idea to introduce this. I think it's something that we can sort of start to do on our own in our own personal spaces, our own social networks at work. So cultural humility, it's a process of openness and self-reflection about our own biases. And it really requires us kind of looking within and being open to others' perspectives and others' experiences. So the thing I like about this is it says that it's an ongoing process. It's not something we can, take a training, take a class, and then we have high cultural humility. This is a process of just being open and honest within ourselves as well as within our own communities. But we know that this is not the only thing that's going to address a lot of these disparities. It's, health disparities and health inequities are a multi-level problem. So it really is going to take multiple layers and levels of intervention and solution strategies. But and I don't think I'll have time to talk about some structural solutions, but I think it is important for us to just think about what we can do personally and, within our own social networks to help start to begin the conversations. Um, so I've also included, I think at the very end of the slide deck, there's going to be additional resources that I think will be available at the end of the session. So I encourage you to look at them. And that's all I have. Thanks for listening.
Thank you, Dr. Wells. We appreciate that. I think it was a great overview of health inequities and definitions that go along with it. Before I introduce and go over some of the accomplishments of Dr. Tobias, I want to ask if there are any questions from our participants, our audience that have been listening in so far. While I wait for those to come in, I do want to talk a little bit about um, my background, and I've worked at the Barrett Cancer Center and at UC, and really have had a firsthand look at some of these disparities that patients, and their families kind of experience. One example that really stands out to me is that I had a 55-year-old female that had newly been diagnosed with cancer. She had multiple medications that she needed to adhere to make sure she stayed on course with her chemotherapy there before chemotherapy and afterwards. And we really just kept trying to figure out through her follow-up appointments why she wasn't taking these medicines. And as we continued to break things down and figure out through her visits, we learned that there was health literacy and there was low literacy in general that caused her not to understand the directions on her medications, and she was taking them inaccurately. Then also thus causing lots of side effects and things like that, and readmissions to the hospital because she wasn't understanding things. Can you hear me better now? Are they able to hear better now?
Yes.
Is that better?
Mm-hmm. You sound good.
Okay, because there's a couple people responding saying that they couldn't hear me well. But the gist of that was just overall, I just had a patient that was, not able to really follow directions on her medications for pre and post chemotherapy, really because she didn't have the literacy to understand the overall instructions, and it caused a lot of side effects, and it caused a lot of readmissions to the hospital because she just didn't understand. She had the disparity of low health literacy, low literacy in general. Any other questions? I haven't seen anything really pop up. If not, we will kind of advance to Dr. Tobias. Dr. Tobias is a medical doctor and family physician, currently vice chair of the Department of Family and Community Medicine at the University of Cincinnati College of Medicine. Go Bearcats. She is the Robert and Mafoy Smith Professor of Family Medicine, where she has served as interim chair for the past 2 years. Dr. Tobias is a 2009-2010 RWJ Health Policy Fellow in the immediate office of the Secretary at the U.S. Department of Health and Human Services. Dr. Tobias is also a medical director at the Health Collaborative, providing leadership and support to physicians and practices in public reporting, payment reform, quality improvement, population health and practice transformation initiatives, including the Comprehensive Primary Care Classic, short for CPC initiative, the CPC and the Accountable Health Communities Initiative. Most recently, she supports the Health Collaborative Emergency COVID-19 Regional Response Strategies Work Group and Community Core Team. Dr. Tobias is a graduate of University of University of Cincinnati College of Medicine and received her BA from Cornell University. Dr. Tobias has practiced family medicine for over 25 years, including over a decade at Lincoln Heights Health Center, one of the oldest federally qualified health centers. She currently cares for patients at Good Samaritan Free Clinic. Dr. Tobias.
Thank you, Jamie. And thanks, Dr. Wells, for that powerful presentation. I also want to thank Mary Jo Philhauer for the opportunity to share the work of our team. And we can go to the next slide. It's mission-based healthcare through diversity, equity, and inclusion. So our team, this was work that was funded by the NIH through the American Association of Medical Colleges and the urban serving universities. UC is is a member of the urban serving universities. This work was funded from 2013 to 2017. Dr. Greer Glazer, Dean of the UC College of Nursing, led our team. And we were charged to work with 5 peer urban institutions across the country to work to increase the regional healthcare workforce diversity. So we're going to talk a little bit about really spinning it another way. Why do we have disparities, and how do challenges in finding a trusted provider exacerbate those disparities? And we can go to the next slide. Thanks. So Dr. Wells talked about health disparities. One of the key drivers around that is lack of diversity in our healthcare workforce. We have data that shows that when you have a healthcare workforce that's representative of the population that it's serving, health outcomes improve. Health equity is where everyone has that fair opportunity to achieve their highest potential. And as Dr. Wells said, health equity is accomplished by removing obstacles that prevent individuals and communities from attaining that optimal health. That includes obstacles to becoming part of that healthcare workforce. So at the time that this work was started, nationally, about 7% of students were Black, according to the American Association of Medical Colleges. At UC at that time, 13% of 173 students were underrepresented minorities, compared to a non-white population in Hamilton County of 33%. Just to define and unpack that URM term, underrepresented minority, that's a term that exists across all medical colleges, and populations that make up URM include African American, Black, Latinx, Hispanic, American Indian, Alaskan Native, Native Hawaiian, Pacific Islander, and mainland Puerto Rico. It also refers to students from disadvantaged backgrounds. Let's go to the next slide. So why is this important? Because patient care improves when, oops, we can go back. Patient care improves when patients and physicians share a common background or language. And racial and ethnic diversity among health professionals has been shown to improve access to health care, as well as quality to meet the health needs of an increasingly diverse population. We know that generational trauma from racism impacts health. In family medicine, we talk about the patient in context, and that context includes family. It includes community barriers to health, and it includes life experiences. In order for a patient to be able to share that context, they have to have trust in their provider. And a trusted provider is truly the key to the patient-physician partnership. We can go to the next slide. So our goal was to work in collaboration with community stakeholders to develop tools to support a diverse healthcare workforce that would increase access to healthcare and optimal health for all of our community members in our local urban community. So we engaged a community advisory board that was led by Senator Eric Kearney, and our team included leadership from Center for Closing the Health Gap, the Faith Community, Urban League, Cincinnati State, Hughes High School, Children's Hospital, the Hispanic and African American Chamber, United Way, and many others. And they helped inform our surveys. So we'll go to the next slide. So our community advisory group helped us understand that the barriers to finding a trusted healthcare provider happened along race and ethnic lines, but were also impacted by the type of insurance that we had or lack of insurance that someone had. And certainly poverty, socioeconomic status, and educational level impacts finding a trusted healthcare provider. Next slide. So interestingly, in 2012, the Robert Wood Johnson Foundation surveyed our community as part of the Aligning Forces for Quality project to learn how individuals were interacting with the healthcare system. They surveyed Cincinnati, Detroit, Cleveland, and Memphis, as well as Kansas City. And this survey included questions about individual perception of discrimination within the physician-patient relationship. It's no surprise that Black African Americans were more likely to respond that they felt judged or treated with disrespect by medical staff versus the whites that were interviewed. African Americans, Blacks also felt they were treated negatively more often than whites based on the type of their insurance or lack thereof. So we'll go to the next slide. So Interact for Health helped ask those same questions in their Greater Cincinnati Community Health Status Survey. So based on the research that trust between a patient and provider is important for creating an effective care environment, they were able to put on the 2013 Greater Cincinnati Health Status Survey questions that asked adults about barriers that might make it difficult to find a healthcare provider that they could trust, and included options like health insurance or lack, race and ethnicity. And the survey asked specifically if either a lack of health insurance or the type of health insurance had been a barrier to finding a trusted healthcare provider. And 2 in 10 adults, or about 19% in Greater Cincinnati, said the lack of insurance or the type of insurance prevented them from finding a trusted provider. However, health insurance coverage is more of a barrier for some groups than for others. And as age increases, people reported insurance as a barrier decreases. So younger people reported that as a barrier more than older people. Among adults living at 100% of the federal poverty level, about 4 in 10 reported a lack of insurance or type of insurance as a barrier to finding a provider they trusted. And only 1 in 10 adults who lived above 200% of the federal poverty level, and at that time it was $23,550. At that time, only 1 in 10 adults who lived above that reported that as a barrier. However, African Americans were more likely to report insurance as a barrier to finding a trusted provider, and 26% reported that their type of insurance was a barrier to finding a provider they trusted, and that compared with fewer than 2 in 10 white respondents, or 18%. And we'll go to the next slide. So we repeated this survey in 2014 and found the same thing. There were a total of almost 5,000 randomly selected adults residing in Ohio counties 9 Kentucky counties and 5 Indiana counties were also interviewed by telephone between August of 2013 and January of 2014. There were cell phone and landline interviews conducted. And again, lack of type of insurance was a barrier, with Black African Americans more likely to report insurance as a barrier than whites, and more likely than whites to report race and ethnicity as a barrier to finding a trusted provider. And we'll go to the next slide. And so this was the data that was repeated in 2017 with an even greater difference between Blacks and whites. So the problem continues to get worse, and we'll go to the next slide. And I think that this is probably one of the best questions. Do you think there was ever a time when you would have received better care if you belonged to a different race or ethnic group, or if you spoke English more fluently, identifying language as a barrier? African American Blacks almost 4 times versus whites felt that there was a time, or reported that there was a time, when they would have received better care, or thought they would have received better care if they had belonged to a racial or ethnic group. And we'll go to the next slide. So perception is reality. There have been other studies in Cincinnati that looked at perception around the criminal justice system, which showed the same thing, actually, from Cincinnati. And we also know that there's reason not to trust healthcare providers. Now, historically, from the Tuskegee experiments to UC's own experiments of whole body radiation between 1960 and 1972, it's no wonder that Black African Americans feel that trust is a challenge in finding a provider. Our community has the data, so we know both in the disparate health outcomes and in the perception of trust. Our academic health center, though, is uniquely positioned to help train the next generation of healthcare providers, to really set an example for our region around equitable care. And to begin to earn trust as a provider, we need to approach the sacred space of healing with cultural humility, as Dr. Wells described. We can and we must expand our healthcare pipeline, starting in preschool, to ensure equitable educational opportunities, and to continue to advocate for policies to address healthcare access. Racism is a public health crisis. I'll stop there, and we'll open it up to questions, and I hope a dialogue. So thank you.
Thank you, Dr. Tobias. That was great, and also Dr. Wells. Just to kind of add into what you all talked about with the slides, a little bit more about my background. I have also worked in the realm of palliative care, and I'm not sure if everybody on the WebEx knows what that is, but palliative care is a service that when patients are dealing with either life-limiting or life-threatening illnesses, we talk about goals and what you want to do with your care moving forward. We also focus on symptom management from that disease process. And a lot of time people think that palliative care is just surrounding cancer care. It is not. It could be if a patient's got issues with their lungs, or if the patient has got issues with having a prior stroke and has deficits from it. So we work closely with patients when they have that. So, as I think more about, inequities, disparities, some things come to my mind, especially through this COVID pandemic. I prior worked at UC with the team with palliative care there. And we experienced a lot of different cultures of people, some African American, some Latino. And lots of times I think that because we didn't whether it be the staff or whether it be our team, we just weren't familiar with that particular background. Sometimes we can have preconceived notions, and you have to break down those preconceived notions so that you can adequately care for those patients and the things that they need, and understand where they're coming from, and what they want in their healthcare and what they want out of their healthcare. And just because they have a difference of opinion of what should be done doesn't mean it's not their goals for themselves. So, I think that these topics, in this first series is definitely a big piece of what we have to do to understand other people and to get the care that they need across the board, no matter what culture they are coming from, no matter what background they are coming from, so that we can all be on the same equal playing field as far as healthcare is concerned. I don't see any questions in our chat box, but I don't know if Dr. Tobias and Dr. Wells, you have additional things to support or talk about. Oh, hold on one second. We are getting a couple things here. Let me go through as we get the questions and see. I think there's one from Tadela. It says, in your study, did community members discuss changes that they wanted to see in healthcare? And are you referencing that, Tadela, to Dr. Tobias or Dr. Wells? Dr. Tobias, please.
Sure, thank you. And I would like to hear what Dr. Wells has to say about this too. Yes, so our community advisory group helped inform this, as I mentioned. Center for Closing the Health Gap has also done many focus groups and around these questions too. I think first and foremost, we all need to understand where our biases are. So implicit bias and conscious bias training really should be part of, I think, of any service profession. Part of what people want in a provider is someone who listens. And I just read a quote this morning, to listen more deeply is critical, especially when you feel you're the expert. So asking patients, as Jamie, as you referred to, what about your family, your background, your faith is important for me to know as your physician, is a way to start to approach that cultural humility that Dr. Wells described. I think that it really begins, as I said, with pipeline. So we have to have a healthcare workforce that looks like us. Preschool age kids need to go to the pharmacy and see a pharmacist that looks like them. We have to have those expectations that maybe everybody in the family will have a healthcare provider in their family to help the health literacy of all of us and all of our families. We talk also about the admissions process as a way to impact that healthcare workforce diversity. And UC was one of the first to go with holistic review. Dr. Mia Mallory, Dr. Chris Lewis in the Office of Equity and Inclusion have made great strides in the way that we function as an admissions committee and how we look at a candidate and what qualifies someone to be an excellent doctor is certainly beyond a standardized test. What about distance traveled, life experiences, maturity? So looking at that, and then recruitment and retention of our faculty from ethnic groups that are underrepresented. We have to have faculty that looks like those students. So from provider, it's really being open, honest, humble, asking those questions, and having a great amount of self-awareness.
Dr. Wells, do you have anything to add to that? If you don't, there's several more questions here that I want to make sure that I try to get to through our dialogue.
No, I just kind of echo the, kind of the need to address, multi-level strategies. So, I mean, we've talked a little bit about some of the structural and the more patient-centered things that can be done, but I agree.
Another question here from Carrie. What advice do you have for two white ladies writing a grant that focuses on bringing URM into our sample, as this is missing in our literature? It is a community-based grant with free service delivery, but I worry about tapping into the places where we can access these folks and about building trust too. We want to have a compelling plan for this to help us get funding and to do the work.
Okay, I can just start. I mean, I think, it might be as a first step to, kind of getting into the community is to align with someone who's a part of the community. Um, I think that's helpful, but some of this it does take a while to kind of develop some of those relationships, and um, it's the community. Um, Typically speaking, the community does want to work with academics, with researchers, but they also don't want to just have academics just come in and get what they want and then leave. So it may take a little bit of front end work from the from as far as engaging with the community they're trying to work with, but in the end, I think it will be a more sustainable relationship, and would likely lead to other research studies and other endeavors.
We do have another question here. It says, I am a critical care worker at UCMC. I also teach clinicals through the College of Nursing as an adjunct. I am interested in getting involved to help the community in some fashion. This information is great. Are the avenues in which where are the avenues in which I can become involved? I can kind of help answer that too. There's lots of resources throughout the city, the Urban League, Closing the Health Gap, sororities. There's, you know, historically Black um, fraternities and sororities that you can be able to reach out to if they're doing community events. I know that there are what have been told is that there are events every weekend in Greater Cincinnati for COVID testing, and you can help volunteer for that. So there's lots of things. I think Dr. Tobias also mentioned United Way. There's lots of different resources within the city that you can kind of tap into.
And Jamie, that's great. I would just offer to be a mentor. And maybe there's someone near you, maybe it's a relative, maybe it's a neighbor. If there's an elementary school or a middle school near where you live, to call up and say, hey, I'm a critical care nurse. I'd love to talk about my job and be a resource for kids who may have that interest. So I think that's a great place to start.
We continue to get more questions. There's Brianna, which I think I know as well. As an African American nurse, F&P student, I am very aware of health inequities. I always make sure to check on my own biases so that I can provide equal care to all of my patients. How else can I play a role in eliminating health inequities?
I think it's the time to be polite is over. I think that it sounds trite. When you see something, say something. Calling out biases in healthcare that have been entrenched. So many of you have seen the study in 2016, which showed that med students across the country were surveyed and had a misperception that African American skin was thicker than white skin, or that African Americans' blood clotted more easily than white blood. We've had racially based benchmarks in laboratory measurements. So pulmonary function tests that were based on measurements made from people who were enslaved, looking at kidney function, glomerular filtration rates, the GFR, which was done on a very small population and had different thresholds for Black versus white. That's recently been addressed. So I think really healthcare providers need to call these things out. We need to be a part of the change, and we need to hold each other accountable with grace.
To try to kind of address Brianna's comment question as well, I think with me working with palliative care, another thing that I witnessed, and this is just another example, is that I had two families that were dealing with a loved one that was dying of COVID. And long story short, the one family was a white family, the other family was a Black family. And because of the restrictions of COVID and coming into the hospital, there was very much a outwardly upsetness from the African American family that they could not come in and see their loved one. But the white family was upset about it, but just expressed it in a different way. They were more docile, more quiet about it, and really having to break down our biases is that, you know, as African Americans, that we are potentially more because we're more boisterous or potentially more outward with what our emotions are about things, does not mean that we're aggressors, and that we are just expressing ourselves because our loved one is passing away from this very horrible virus, right? So really just having to go and talk to the staff members that were dealing with that family, the nurses, the physicians, and really breaking down our biases and saying, let's look at both of these cases and talk about what we're experiencing and why people are reacting one way or another. And as we got through that, we came up with innovative ways so these families could be able to see their loved one without being exposed. We've got more questions here. Let's see. From Rosanna Nelson, it's my sorority sister. Hi, Rose. What can members of the large community do to address the disparities and inequalities that have been presented? Then she also adds, I meant to add community members who are not necessarily in the health field.
I can start with that. You know, I'm finding that there's more, I mean, I'm just, I guess, recognizing more of a need for there to be structural change and more institutional sort of approaches. I think, patient-centered care and cultural humility, those are all really, those are great things. And that's, it is important at all levels. But I think a lot of these like really complex intersectional types of issues really are probably going to be only addressed, I mean, like really start to be addressed through change in policy, change in in funding streams, sort of those really hard issues. And it's, I would like to see more people who are in it, who are in positions of power in leadership to actually just start to kind of address some of this. I mean, I think we're trying to. I think especially with the events this year, but the more I look at this, I really think more has to be done from a larger macro structural um, approach, which a lot of it requires money and time, a lot of time. But
Thanks, Dr. Wells. I agree that behind population health is policy, and unfortunately, behind policy is politics. But there's an opportunity in November to vote, and I think that's how we shape policy. all of health policy is local. And we saw that the city of Cincinnati, the county, and the state are all recognizing racism as a public health crisis. So lending our support for that acknowledgement is a part of that.
Yeah, and just a part of that, if you haven't done your census survey, it takes like 7 to 8 minutes. Do it, because that's a part of impacting policy as well. So,
And, I think that we've had a great dialogue, but in the interest of time and knowing that it's evening, that was our last question that we can take. The other questions that have come through our feed on the chat, we will make sure that we forward those to the appropriate presenter, Dr. Wells or Dr. Tobias, and we'll follow up with you on those questions. Once again, I want to thank Dr. Tobias and Dr. Wells for presenting this evening. And I also want to kind of put a plug in for our next session, WebEx, and that'll be hosted on November the 5th, 2020, Exploring Our Patients' Context, A History of Anti-Black Racism in Cincinnati. Our presenter will be Dr. Anna Gornecki. I'm probably not saying that correctly. She's the program director at Geriatric Medicine and Fellowship Program at the Christ Hospital, an assistant professor of family medicine at the University of Cincinnati. Thank you for you all's time. Thank you. Have a good night.
thank you.